10:30? Did you guys need to do your thing first?
We're supposed to introduce you guys, but we don't.
You don't have your script. Okay.
But if you guys just want to start, then I don't see a problem.
Okay.
Yeah. And then if you guys can introduce yourselves and like your bio, just like something quick.
So I'll introduce like the organization and then
Yeah.
I'll hand it off to them. They'll introduce themselves and it's so yeah, don't worry about it. I think we'll be fine. It's all good. I didn't memorize their bios neither, so I can't hold you to that standard.
And then you guys want me to hold up questions until yes.
Yeah, we're gonna hold on.
Sounds good.
I think we are at 10:30, so I'm going to start us off. My name is Maisha Amare-Herrera, and I work for Hawaiʻi Soup, which I will explain in a little bit. We do have a number of speakers here this morning, and so we are going to hold questions till the end as we all go through. And so we have Angela Bolan from DOH here, and then we also have Hawaii Cares 988, and so we're just going to all take turns, and we'll go through. So as I said, my name is Maisha Amare-Herrera, and I work for Hawaii Substance Use Professional Development, and that is a mouthful, so that's why we shorten it to SOUP. If you guys get a chance, visit our table. We have an exhibitor's table out there in the hallway as well. So Hawaii SOUP is a partnership with ADAD, the Alcohol and Drug Abuse Division from the Department of Health, and we have a collaboration to look at the substance use workforce in the state of Hawaii. So when we are looking at substance use, we know the impacts it has. I think everyone sees it in their everyday practice, in their everyday lives, right? Whether it's personal or professional. We know that it impacts interpersonal skills and relationships, economic factors, and then those are addressed by our systems, our healthcare systems, right? And our child welfare system, education. So we see it across the board. 14.9% of people in the US needed substance use disorder treatment. And of those, 97.5% who didn't receive treatment believe that they don't need it. And we know that we don't see people unless it's gotten severe, right? We're not the first point of contact. We know that people reduce their use on their own or within their family systems and the supports that they have. So we know that we need more people in the workforce, and to do that, we need to address recruitment, retention, burnout, and training. So when we're looking at the behavioral health workforce, we have, all of these lovely professionals here, but we're also expanding it. We want the community to be aware of substance use issues, and so that also includes what we are calling adjacent professionals. So that's going to be your librarians, your school systems, your teachers, your counselors, community groups, and other coalitions. So right now, ADAD has 5 different substance use certifications, and these are the 5. And I'm sure you guys have seen some of them. If not, come out and talk to us about it at our exhibitors table. But the one I did want to point out is that they are developing a certified peer recovery specialist certification, and so that's going to be one of the newer ones. And I will talk a little bit more about that. We have about 548 certified substance abuse counselors, so your CSACs, and that is the most, or the highest number of certifications, so sorry. There are 5 certifications, so this one has the most number of people that are certified. And again, looking at this, we also have close to that number in people who are in process. So we know that we need to get those people that are in process actually certified. Looking at some others, one of the things to point out about our prevention specialist numbers is we actually have more people in process than we do actually certified. So we are looking at what that means and talking to people, and I'll talk a little bit more about some of the data that we've collected later on. And this is for our certified criminal justice professionals and then our certified substance abuse program administrators. Sorry, these guys, the certifications are tongue twisters if you're saying them all together all at the same time. But we have the least number of certified, or CSAPAs, the administrators, and that, tracks, right? We have less people at the top and so less administrators that are certified. So our project is approaching workforce by developing the certified workforce that already exists. We're offering free trainings, and we'll talk a little bit more about trainings in a bit. And so that helps them to maintain their certifications and stay certified. We're also building the substance use competence of adjacent professionals. We do community training, so we'll go into a school or a library and help to train the staff that are there as well. And one of the things we're doing a little bit more now that we've kind of settled in. We've been a project for about 3.5 years now. So now that we're getting settled in, we're starting to look at recruitment. And so we've got some student efforts that I'll talk about in a little bit, but again, we have some flyers and things at our table you can go and check out. I'm gonna talk some about training, our student efforts, and then some of our evaluation numbers. And so you can tell when we get to our evaluation and assessment stuff, because it'll be wordy slides. So for trainings, we've got our in-person trainings, our Zoom trainings. I think you guys are pretty familiar with those. Those are kind of the standard right now, right? We've also, on our website, started our training vault. And so our training vault has our asynchronous trainings. We are able to record our trainings that have happened. We attach a knowledge check to them, and then we're able to give CEs. Right now, we give social work CEs, continuing education credits, and also for the ADAD certifications. And we're looking to expand that. You know, we'd like to see maybe some CMEs for some of our trainings. We've also done partnerships with the Hawaii Psychological Association to offer some of those CEs as well. And then lastly, we're partnering and collaborating with other entities to provide trainings. So we worked with UCLA this past year to do some of our ethics, confidentiality, some of those standard ones, but it really helps to increase the impact that we're having when we are kind of a smaller team. So this training data is from the first 3 quarters of our fiscal year. So this is just the trainings that we did as Hawaii Suit with our trainers. So we had 37 trainings. One thing I wanted to point out is the 1,681 attendees. That's just the total attendance numbers. We have not actually selected out, you know, the individual participants from that number just yet. And 5 community trainings like I was talking about before. With our partnership through UCLA, we did 17 trainings, including some in-person trainings that we were able to do on neighbor islands. So now that we've kind of established trainings here on Oahu, we want to make sure that we're meeting the needs of communities outside of Oahu. As you saw with the certifications, right, the majority of them are going to be on Oahu, which is where, you know, the majority of the population is and all. But we want to make sure that we're reaching other communities that may not have access to in-person trainings, right? There aren't going to be as many in-person trainings, and we just want to make sure that we're reaching everyone. We've also partnered with Department of Health to do some trainings, and the Legal Action Center. Sorry, I realize we've got acronyms and alphabets all over the place on this slide, but we are always looking to collaborate to increase our trainings and to get information out to people. Oh, and these are pictures from some of our trainings. We look like a lot of fun, yeah? So as I mentioned, the peer recovery certification is something in process that Angela can talk about a little bit later. But we are partnering with Papa'ololokahi to create a culturally focused curriculum. So while there is the standard peer recovery specialist certification curriculum, we're looking for them to create a cultural component and actually integrate it for us, because we know that sometimes things that come from the continent don't necessarily work here, and we want to make sure that we're equipping people as well as we can. So this is, I'm going to kind of breeze through this, but this is our QR code to our training vault. All of our trainings, like I said, are free. We're constantly working on new trainings to get up there so that we can get new things out. Currently, they're all listed just as a big long list in alphabetical order, but we are going to be starting to organize them by, like, you know, everybody needs the ethics. So we need to start highlighting those ones, and just we're realizing that the more we put up there, the more organization we're going to need. So with our student opportunities, we piloted a program last year, and we had, which we're calling the SOUP Scholars Pathway. And so we're working with MSW students and seeing where their program requirements for their MSW and the certifications for CSACs actually overlap. So there are specific courses that they can get counted towards their training hours. Having a behavioral health degree also reduces the number of training hours that you need for your certification. And then we're working with them to get them in substance use field placements so that they can actually start earning their work verification hours. And so we piloted it last year, and we're wrapping up recruitment. I think we have 4 for this year, and this will be the first year that we're actually having a student that is not in the MSW program. And so we're still going to work with them on certification, offering support. And we do information sessions that we then also have on our website. So if a student made their way to our website, they can look at our program, but even if they're not part of the program, it's still to help them plan, right? If they're planning to get their CSAC, we want to make sure that they're aligned. In the future, we are, again, looking to open up to more degrees, but also different certifications. Right now, we're very focused on CSACs, but we want to start looking at prevention specialists and maybe some of the criminal justice professionals as well. These are our 2 SOUP scholars from last year. We, as I said, just wrapped up recruitment, so we have 4 students, and we're gonna get their pictures and bios. We'd just like to put them out there. You know, we're proud of them. We want them to do really well, and they're also posted on our website. The other student recruitment tactic, I guess, if you will, that we're starting is we created these 2 flyers that are specifically meant to go out to our high school fairs. So our School of Social Work's recruitment team has worked with us, and so they take it to their fairs that they go to. These are ones that we just created this year, and the one titled Interested in Behavioral Health and Advocacy has a little quiz, you know, that you can take, and oh, if you answered these things, then you might do well in this. So just kind of suggesting things, planting the seed. I don't think people talk about careers in behavioral health as much as we'd like to see it done, right? And so just having that introduction is where we want to start. So as we head into assessment and evaluation, we have different data touch points that our project is working on. From our trainings, we collect registration data, and then we have post-training evaluations. I'm gonna talk a little bit more today about the frontline staff survey and the provider surveys, and then after those, we actually did focus groups and interviews. So we have some of the preliminary data from those research efforts. So our provider and frontline surveys went out through our listservs for training, through provider agency listservs and distributions to different community partners. And we ended up with about 108 survey responses for the frontline staff survey and 43 for the provider survey. So we'll talk a little bit about the themes that we saw from those. So starting with the provider survey, those went out to agencies specifically. And so they were filled out by agency leadership, administrators, whoever they actually designated to fill out the information or who would know that information. And we had 43 agencies responded. We had a really wide range of the types of agencies that we saw. So we had some with 2 employees and some with 300 employees. And their most common staff that they employed were usually treatment staff, case managers, which makes sense, right? And down to the less common, which were recovery support and medical staff within those agencies. And so a lot of the agencies primarily focused on treatment for adults. Again, not surprising because that's how we distributed the survey, right? Is sending it out to providers through the listserv. Things that we saw regarding the workforce, they were really flexible in the work requirements when they were hiring. So they would accept live experience. They would accept certifications that were in progress. They didn't actually have to be certified already. And a number of them had on-the-job training arrangements where you would start with them, then start your certification process. And along with that, there was a wide range of educational standards. High school diplomas, that is the minimum education required for certification through Department of Health, Alcohol, and Drug Abuse Division. So that also was not very surprising, but all the way up to master's degrees, graduate school degrees. And again, CSAC was the most popular credential in all of those. So looking at the vacancies, 44% of the agencies noted having vacancies. That may not necessarily be surprising. It is a little bit concerning, right? There's a lot of vacancies out there, and we want to make sure that we're working to address those vacancies. So common reasons, somebody left, and they were having trouble hiring, and they didn't feel like they had qualified applicants, or they couldn't afford a sufficient salary for those workers. And common indicators for reasons people left positions were for career advancement. They were offered positions elsewhere. They moved, or again, for higher pay. And I think that's a theme that we'll be seeing throughout these slides. So ways that they're working to retain employees. If they can, they'll offer a pay raise or promotion within the agency, but also supportive and consistent supervision. And so one of the questions that we had on the survey was surrounding supervision, and we're hopefully gonna have more data on that later, but also flexible work hours. You know, if they can offer flexible work hours so people can maintain some of their own mental health as providers, right, it helps to keep people in the field. So our frontline staff survey went out to those who should be out in the field and working with clients. And so we had 108 people respond. And they tended to be, we have older on here, but we're gonna say more experienced. They have more years and experience in the substance use field. They also tended to be educated with bachelor's or graduate school degrees, which we found pretty interesting. The majority were female. Again, I don't think that anybody working in the substance use field is super surprised by that. And nearly 40% of those that responded identified themselves as being in recovery. Most of them reside on Oahu. Again, we see that with a lot of our numbers, but we also got representation from other counties and neighbor islands. So looking at the support that is offered, the vast majority of people thought that their agency believed and supported them going to trainings and getting their certifications. But the reasons that they weren't going to trainings were often the lack of time. It's hard to fit into their schedule. Maybe they didn't have funding, one of the other reasons why we offer free trainings. But you know, one of the things that we found interesting was there was a few that said they didn't see the benefit of attending training. And so that's something that we're looking at, right? We want to make sure that our trainings are useful, that people are gaining things when they're coming to our trainings. So they identified these topics as the things they want to learn about the most: clinical skills, trauma and mental health, cultural competency and diversity. I think is something that we're seeing a lot within our trainings and things that people are requesting, which is, again, one of the reasons why we're looking at we are partnering with Papa'ololakahi to try to address some of those pieces. And then substance use treatment practices. And this is really interesting because we're looking at the substance use workforce, but substance use treatment practices aren't necessarily the first thing on the list, right? And so we want to look at this more broadly as behavioral health. And then areas to enhance work quality, again, kind of similar to the training topics that we saw. Excuse me, my throat is getting a little dry. And then what they would need to grow in their current positions. They're looking for more training and CEU support, supervision, funding and staffing supports, and more culturally relevant training again. So we're seeing this theme coming up in all of our training questions, right, of what they want to learn. So overall, we know that there is a strong belief that agencies support training opportunities for the workers, but there's a lot of common barriers in scheduling, followed by funding, energy, and interest. And the largest motivators for training, to attend trainings are access. We know that it's a little bit harder for neighbor islands to find in-person training. And so making sure that we have some online trainings, asynchronous trainings to help fit the schedules and fit the accessibility issues. Relevance, and then also incentives. And most workers believe that they have the tools to grow in the job that they're at. So we, again, want to look at how do we retain that workforce. But we will have more survey findings to come. This is just a taste of what we are doing and our initial results. And then we will be also reporting out on the focus groups and interviews that we had to help contextualize some of the data and some of the questions that we were seeing. Quick shout out to our advisory board. We meet about every other month and we present to them what we're doing, what efforts we're doing, we ask them questions about what they need, and we ask for feedback. And so they are great and they are committed to our work, and they like to see what we're doing, and they like to stay honest. They definitely keep us accountable, because if we say that we're gonna start doing something, they're like, hey, what happened to that? Where is that? What are we doing? So they are fantastic. You can engage with us through our website. We are currently under the Department of Social Work, or Thompson School of Social Work and Public Health website, but we have a short link here, and I have a QR code there at the end. You can learn more about our program, our SOUP Scholars program. You can see our trainings, and we have a training calendar up there as well, all kinds of community things that are coming up. So I'm going to turn it over to Angela Bolan from Department of Health, Alcohol and Drug Abuse Division to give some updates on what they're doing.
Aloha, everyone. My name is Angela Bolan. I'm from the Department of Health under the umbrella of the Behavioral Health, and we are located in Kapolei, the Alcohol and Drug Abuse Division. Particularly in my office, we're the Quality Assurance and Improvement Office, which we offer all our certifications that Maisha mentioned, as well as our training component. We also do accreditation for our therapeutic and residential services, along with the registry for our clean and sober homes. So there's a lot of stuff that's happening in our small little office. We're about 40 plus right now, I think, strong in our division. Prior COVID, we had 13. So to manage that as the leading authority for substance use professionals was really struggling. And so as everyone have challenged with workforce, the state as well has done so. but we're slowly moving up and finding ways of how to be successful in retaining and recruiting individuals. So the Alcohol and Drug Abuse Division, as we identify as ADAD, our main goal is like leadership to provide and develop the necessary substance use prevention and interventions for the residents of the state of Hawaii. Oftentimes, we are the sole provider as far as funding for these organizations to support the services needed for our communities. So, we take a lot of information from our stakeholders as well as community to provide the necessary innovations that we want to help for the workforce and those seeking services. The Alcohol and Drug Abuse Division does not do services, but we contract a lot of that out. Part of it is training components, and as you will meet the 988 team later on, and how to reach out to the state and the residents. One of the things that we talked about as far as workforce is really aligned with the cores of the federal government back in 2014, 2016. The federal government, SAMHSA, had reached out to the Department of Health and collaborated with different organizations to provide support as far as looking at the workforce within the state of Hawaii, which the components were not only with the mental health, behavioral health, substance use, but also medical. That's where I originally met Dr. Kelly, and she was one of the team members that was trained and went down to the federal government back then. We went quarterly to find out what we would do to help support the local community and how incentives, and since then, we've always been supporting the workforce, whether it's with the projects she does with ECHO, as well as the projects we do with our substance use prevention and intervention programs. However, one of the core functions, or some of the core functions we look at in order to address workforce is really the cores of system-oriented leadership and principles. We also look at assessments and interventions, skill-based approaches. Are we looking into broadening our topics in which we want to have for trainings? We want to look at more of that. Another thing we kind of emphasize is sustainability and quality improvement. Continuing to look and identify the strengths for short-term as well as long-term approaches for our workforce, and improving services that include not only what the state is evaluating, but also getting contributions from our community and stakeholders in order for us to assess the strength and validity of our field. We also look at information and communication. How is that being productive in our process? Are we doing enough media campaigns? Are we going out to community events to share what we support? Oftentimes we've heard in the past with other professions, we don't know who the substance use professionals are. How do we get our services, or how do we get services from them? Well, the more and more we can get out to share what we do, the more collaboration will start to improve. And that is necessary for the wellness of the patients that are being served. The other part we're looking at is the cultural placement-based approaches to services, as well as training components. The one big thing that I did research when I was in my master's degree was on burnout. I think that was one of the things that was really profound, and I really emphasize this even with today's students that I have, that I intern with, looking at the holistic wellness and safe care of our professionals. We have to incorporate that in our workforce because that is important for the wellness of what comes out and how do we incorporate that. One of the challenges within the training component, and Maisha them knows, is that I want to always have some form of self-care and self-awareness within the process of our trainings, because we cannot help people if we can't help ourselves. So we need to realize and take care of ourselves. And oftentimes we talk about it, it's really hard, but we have to try to carve out that. And for our workforce and our employees, providers, take heed of that, where that maybe you can carve out some of that time, because if not, then we will continue to see burnout throughout our field. One of the things that the state of Hawaii also have done, at least for our recruitment part, is explore other areas of recruitment. And so that was one of the things that we did. We looked at strategies to retain the professions. The Alcohol and Drug Abuse Division did a rate schedule for our treatment and prevention providers, at least to align and look at the service modalities as well as what is being paid out. And are we giving our providers sufficient enough funds in order for them to operate and have a life, go into this field having some opportunity as a life career. One of the things we also do is looking into temp hires as filling up spots. That was definitely something I think throughout many of the different organizations and state offices we had to do in order for us to maintain some of the services that we do. We also looked at reassigning the schedule levels of our work to be able to widen our candidates to get the position and then mentor them to get to that level. So there are some things that we do at the state level currently right now to help in order for us to expand our workforce. As Maisha told you earlier, we do have 5 credentials currently in the state of Hawaii certified for substance use professionals. One of the things that we'll be passing within this year is our peer recovery specialists. It is vitally important that peers are placed in certain areas, whether it's in our treatment services, hospitals, EMS, police. These are important components that can help with the factor of not only the workforce, but also to allow people that get the service to be engaged in more trustworthy approaches. You know, oftentimes they come in and they're a little bit more reserved. This way, peers often help. We're working with MedQuest right now to look at opportunities for billable service. There's other states that have billable services for peer recovery specialists. So we're working with them diligently to make sure that some of the state laws will be changing in that to include contingency management programs. And we will be having some trainings on that too. What does that entail? You know, reinforcing behaviors to incentivize recovery. One of the things we're also looking at into is we do accreditation. We are going to be working at passing some administration rules within the next couple of years to oversee outpatient services. Currently, right now, we only do our therapeutic living as well as residential special treatment facilities for substance use disorder. Our hopes is to go into outpatient services. And reason behind that really is oftentimes because some of the rural areas cannot contract with the national certification accreditation. And so that leaves them not the opportunity to contract with medical services, you know, to help with their services. And they solely rely on the Alcohol and Drug Abuse Division for their funding. Our hopes is that the state will, the DHS will recognize, the Department of Human Service will recognize the state accreditation to be applicable so that these rural and small operations can then contract with them. So, you know, lots of stuff happening on a state level, lots of things happening for workforce. We're encouraging our partners to continue giving us information of what challenges are happening so that we can make more productive approaches on our procurement process, how we contract. So those things are taken into consideration. That's all I have today. Thank you.
Thank you, Angela. We're now going to hand it over. You guys can stand up here. We're going to hand it over to Sherrie, Sasha, and Nalu from Hawaii Cares 988. And here's, oh, we need to switch the PowerPoint now.
Thank you. Half an hour, right? Okay, so aloha. So what we're gonna do is we're gonna mix it up because you guys have been sitting for a while and we know that this is probably the session right before lunch. So we need to be able to practice what we preach. And in listening to Angela, she was talking about burnout. And it's very important for us as providers to be able to take care of ourselves, right? Because if you're not able to have self-care and you're burnt out, being able to be effective is just so challenging, okay? So I'm gonna ask you all, kalamai, noho ilalo, stand up. Okay, noho ilalo, stand up, everybody, okay? And what you're gonna do is everybody's gonna go ahead and take a deep breath in and out. A deep breath in and out. Last one. A deep breath in and out. Okay, now humor me. Gonna wiggle, wiggle, wiggle. Okay, for real. Okay. Now you guys can sit down. Okay. So, once again, aloha, we are Hawaiʻi Cares. And the reason why we wanted to start off like that is because Hawaiʻi Cares is the 988 partner in the state of Hawaii. And what we have to do is we have to make sure that each of our providers is taking a look at the mirror and taking care of yourself first. Because how can you be taking those calls when somebody has a gun cocked to their head if you're not taking care of yourself? If you're having your struggles, if you're having your own anxiety, it is just challenging. So in our call center, we try to malama each other. We try to work ohana-based. And throughout our presentation, we'll give you guys more information about what makes us roll, okay? So we're gonna start with our introductions.
Hi, my name is Sasha Farmer. I'm the Crisis Program Specialist with Hawaiʻi Cares 988.
I'm Nalu, Substance Abuse Division, Crisis.
Aloha, I'm Sherrie Freitas. I'm the Executive Director of Behavioral Health Services. I kind of joke sometimes that I'm the janitor because I gotta make sure that we're doing what we gotta do. Okay. So, giving a little bit of an introduction before we get started. The state has actually gone through a couple of changes with the contract. And currently, Care Hawaii is the contracted provider that now does the 988, the behavioral health version, as well as the substance use division. So in our slides, we're actually going to be able to have it collaboratively, in which we're going to be able to discuss the whole spectrum of care that's provided through the state of Hawaii, as well as American Samoa.
Okay, so the learning objectives, how do you get in touch with us? There's many different ways, right? There's the 808-832-3100 number. There's also the 1-800 number, also 988. We also had included text and chat. So many different ways of getting a hold of us.
Okay.
Wait, was that wrong?
Ay, so okay, next one. Okay. So what is Hawaiʻi Cares? So the CARES is actually standing for something. So that is actually the Coordinated Access Resource Entry System. So when you see that, that's basically letting you all know that we are an entry point that can help you to get access to various services through the state of Hawaii.
So we work with SAMHSA's no wrong door policy. So no matter how you come across our desk, what number you call, you'll get service if you need help. So you can come from any of the numbers and we cannot refuse you, especially they'll run the criteria of what you need.
And just to piggyback the no wrong door approach, we, with the substance abuse, we're dealing with a lot of co-occurring consumers. So maybe the person can call with substance abuse first and present with some mental health issues. So we do a warm handoff. So you talk about the partnership, they're able, and we like to maximize services at Hawaiʻi Cares 988 to provide stability or stabilization for our person in crisis.
So it works, this is call flow. The call flow is we get a phone call, they'll assess if they need substance abuse treatment. First in the assessment, they'll see if they're suicidal, if they're in crisis, they're a danger to themselves or others, and if they have substance abuse, while they're sending out a CMO, they'll send a call up to me. I'll do a substance abuse intake. I'll refer them out to treatment, and they will assess. I can send them back downstairs to see if they need mental health services and stuff, and then they'll refer out as well.
So the key collaborators here are Department of Health AMHD, as you guys can see, also with ADAD and Care Hawaii, and also CAMD services.
So now we're going to tell you about what we do at the, it's actually supposed to be upgraded, contact center, not call center. And the reason why it's not a call center anymore, it's a contact center, is because we actually do multiple modalities, the calls, text, chats, but we also do calls out. And we'll be able to explain a little bit more about that also, because we're also doing it to help with the prevention of suicide.
Okay. So what is Hawaii Cares? You know, we're, Hawaii Cares is 24 hours, 7 days a week. We're open 24 hours, 7 days a week. We provide services statewide, including American Samoa. It's free of service. It's available to adolescents all the way up to our kapunas. Yeah, one of the beautiful things at the contact center that I've grown to love and cherish is that we're culturally competent. So there's services that we can link to should we not have, like for me, I speak Ilocano and Tagalog and English. So if we have a caller that can't speak that much English and they're Ilocano, they can transfer the call to me. Should a person not be available, maybe they talk Japanese or Chinese, we have access to those services to include interpretive summaries, services. So we do risk assessment, we do crisis intervention, suicide prevention, we do a lot of things. We provide therapeutic support over the phone. We do a lot of linkages at Hawaii Cares. Like what Sherrie had made mention earlier, we are Ohana. The way how she has it set up is Ohana based. It's not cubicles. It's where we're able to flag down another employee should we have a difficult call. There's a certain type of call that we are in need of assistance, which is our active rescue. When we're having to dispatch 911, an employee at Hawaii Cares is never left alone. They have the support, and that's how Sherrie has it set up. So I'm very grateful for that.
Okay, so when did 988 launch? Does anybody know? Perfect, you guys can read, yay. So before that, it was only the crisis line, yeah? So after July 16, 2022, lots of changes, lots and lots of changes. That's where the contact center went through a great transformation with increased expectations and increased data collection. So I will overwhelm you guys with data in this next couple of slides too.
So text and chat. It was launched September of 2022. One of the beautiful things of text and chat, also it's available 24 hours, 7 days a week. It's, you know, for the teens, right? A lot of times this is how the teens talk to us. That's how they converse nowadays. Sometimes text and chat, it's like for adolescents, I've seen that they used it because maybe their parents, maybe their family members are the triggers. And this has provided them a segue to communicate, right? So text and chat has been very useful. I just want to tell you folks a little story of how text and chat has been beneficial. Let's just say we're dealing with a lot of homeless people. They have a phone, but they don't have phone service. They can reach us if they have access to Wi-Fi, right? So I've had to deal with a homeless woman who had a phone, but couldn't call in. There was trouble. So we were able to text and chat, and guess what? I was able to send out a crisis mobile outreach worker to her. So you talk about diverse ways of getting assistance, and text and chat has been beneficial in that area. So it's also beneficial for the people who are hearing impaired. So that's another way how we're reaching out to multiple people out in the community.
The thing I love about text and chat is it's super cool because most of the phone calls that we get regarding the kikis is because a school flagged it, a parent flagged it, one of the providers flagged it. And then we send a CMO and the kid's like, I don't get the problem, they get the problem, right? But when it's text and chat, it's actually kiki driven, in which they are reaching out to get help in the way that they feel comfortable. So it makes us challenged because we gotta know skibby dibby, we gotta know drip, and we gotta know if that's not cool anymore, and we gotta know sus. And I hire from like fresh from from college to like the kupuna status. So how are you gonna get one kupuna that's like, what is sus, baby girls? So then we gotta talk, and we have to talk to our keikis, our nephews, our niece, because we gotta stay hip, because otherwise, how can you communicate? We have to be innovative. We have to be able to look at Urban Dictionary. We have to talk to each other, because otherwise it's going to be a deterrent to getting help. And at Hawaii Cares, one of the big things is lots of review of data so we can figure out ways to reduce gaps in services and make it as easy as possible. So if we got to start speaking sus and skibby dibbies, we're going to do it.
And it was very interesting when it started because I had to get acclimated to how the teenagers were talking. I had one text, this person kept calling me bro. I was like, I'm not your bro. But I got to find out from my teenage son, that's respect. So having to learn, when somebody calls you bro, it's where they have found themselves being comfortable and it's addressing you in a respectable way. I was like, so I ended up calling my son bro. He goes, Mom, that's the wrong term.
Yes. Next. Thank you. So data. As you can see that for text and chat, that's something that we have a lot of. So we have about 1,233 texts in a chats in a month, and then we have about the monthly averages was 211 chats and 102 chats. And the difference between a phone call and a chat is actually the amount of time one of my crisis counselors is invested with them. Based on best practices, a text chat averages at 45 minutes. So that means I got one of my Sashas off of a phone call for that text chat. So that's why with the 988 challenges, we had to make sure that we increase our workforce to meet those demands.
And this is the 2024. Okay, you go. Okay, so as you guys can see, this is the 2024. The prior slide showed 2023. So we're continuing to gather data, and the importance of gathering data is how we can best support the people out in the community based off of text and chat or the calls. And that's one of the things that Sherrie does every single time. Meeting with the state, meeting with our IT to gather all the information. And we have programs that gathers all this data. And we're trying to hone in and trying to improve on the services so that we can meet the needs of the community or the person in crisis. So as you guys can see, the totals of text and chat has increased. So so that's our text and chat.
Thank you. Presenting issues. So as I mentioned earlier, one of the things that we are trying to do is we try to track the types of calls that we have, and that helps us to be able to see and provide the feedback to CDC, to SAMHSA, to the state levels, and to the federal levels as to, are there any services that the state of Hawaii should need to be able to meet the needs of our consumers or our residents, right? So what we're seeing right now is the highest number of calls are coming from the mental health and behavioral health issues. And also, one of the unfortunate things is the hang up and wrong number. So what we see for the hang up and wrong number is actually a lot of times people it's kind of like relapse, right? You gotta test them, you gotta test them, you gotta test them until you feel like, okay, now I can call. So it's like, oh, I chicken and I'm like, call yet. Hang up. Oh, and I'm like, and then they get the courage and then they talk to us. So that's why we have to track it, because some people were asking us, why do you track the hang-ups? It's because we're also being aware that sometimes it takes the engagement, it takes them to feel comfortable to be able to make that step to reach out.
So how do we get the presenting issues that's logged? We have a call log. We have a call log, and we've been trained to assess the risk, right? So we have routine, urgent, and emergent. So that's how we get these numbers, and we're trained within the first 5 minutes to identify what the presenting issue is, and that's how we navigate through the call.
Okay, You want to do this one? Okay.
Okay, so here we have the Crisis Center 2024 inbound contact. So as you guys can see, we have the routine, urgent, emergent, and also unknown. So our calls, routine is our frequent callers, or people are calling to get linked or find out information for other agencies, or the people who are just wanting to talk. These are our routine calls. The urgent calls, as you guys can see, this is where they're having suicidal ideations, they're having a mental health crisis, and we get to dispatch a crisis mobile outreach worker. As you guys can see, the numbers here on the urgent for 2024 was 32,159. For emergent, this is where they're suicidal, but they're not able to agree to a safety plan. Maybe they're using drugs, they haven't been on their medication, or they're having suicidal ideations with the plan, and you know, that's where our emergent comes in. That's where we're having to dispatch 911 to assist. So we categorize all our calls to assist immediately based upon their needs. So here we have the Crisis Center inbound contacts. As you folks can see, this is where inbound contacts. So the total inbound calls that we had in 2024 is 113,941. So don't think that we're at the contact center and we're not taking calls. We're taking a lot of calls, and it's constant. You know, the average calls that we get per day could range anywhere from 200 to 300 a day. And I don't know if Sherrie had mentioned it earlier, but we have 45 screeners on board.
So there are days that we peak, and a lot of times it depends on what's going on in the community. A low day could be about 100-something calls. A high day could be as much as 500 something. So like, you remember like with the Maui fire sometimes, or if there's kind of like a the election or stuff like that, or like federal cuts, spikes. Okay, so this is our heat map, and this kind of just shows where the calls come from. So Oahu has the highest number of calls, followed by Hilo and then Maui. And that's something that's interesting too for data, because a lot of people thought that based on the Maui wildfires that Maui would have been second, but it's still Hilo that's second for reaching out. And then we also have other state. So that's because a lot of times, like, people will ask us, why other states calling you guys when they have their own? They'll actually tell us, because we like how you guys are. We get treated with aloha. The other ones will often rush us off. So we try to make sure that we can keep the calls going, because we want to make sure that our resources are for the people that live here, but we cannot also just say, mwah.
So here, Hawaii Cares call data, our average length of call is 6.75 minutes. And then our average talk time is 5 minutes and 32 seconds. So I had made mention earlier, we're assessing based off of needs. And we don't want to be on a call 45 minutes when a person is suicidal, right? We want to be able to send out a crisis mobile outreach worker to the person in crisis as soon as possible. So that's another thing that we're trained on.
And piggybacking on that, Sasha had talked about how we have our triage, right? Urgent, emergent, and routine. So this helps us to know, like, kind of our pacing as to how long we're going to be trying to stay on a call. So it depends on, like, if we know that this is a routine, give them the information, roll the call over so that you're available to have that line for somebody that may be urgent or emergent.
Okay. So we're going to talk about our crisis and suicide call center services.
So this was actually, unfortunately, this is kind of old data, and the reason why it's kind of old data is because this got to us by our epidemiologist, and we're still waiting for more current information, but as you can see, the state of Hawaii is the 12th lowest for suicide, and that was based on the time frame of 2018 to 2022. So I'd really like to see what it is currently, because there's been a lot of different changes along the way since then.
So our crisis support services, I had mentioned earlier a CMO. So CMO is our crisis mobile outreach worker. any individual, whether it's youth or whether it's an adult, they can, if they're wanting a crisis mobile outreach worker to come out and assess them or for linkages, they can. It's a face-to-face intervention. The CMO has about, per AMHD contract, 45 minutes to an hour to show up. So this is where they do a lot of assessment, a suicide lethality assessment, risk assessment, and a lot of linkages can happen, yeah? One of the services that they can be linked to, should they not have long-term case management, they can be referred to a temporary case management, which is CSM for 30 days. Often, one of the beneficial things about having a CMO is, let's just say a person who doesn't speak English, again, or who can't read and write, and they need help having to navigate through our system. That's where the CMO can assist.
I wanted to give the small disclaimer. So a lot of times when people call us, and if they didn't have like their best response time or not the best experience, they often assume that the call center is the same people that's going out. It's actually separate providers. The Hawaiʻi Cares contact center, we're at the contact center, but we dispatch for these services.
Another thing too, in order to access our other services, which is our CSM, a CMO needs to go out. So it's not that somebody can call, oh, I need temporary case management. No, a crisis mobile outreach worker needs to come out and assess the situation. We also have our stabilization units. A CMO needs to come out for that as well.
You wanna go? Go ahead.
Oh, okay. Okay, so this is a slide with our CMO 2024. It's just showing you basically for the month on how many CMOs was approved. So 2021, that's when COVID hit. So we had a lot of CMOs going out, 8,000, right? 8,083. So this is where a lot of CMOs had assisted. A lot of people were in crisis because no child care. The state had shut down. So all these different things. So a CMO can go out for anything. You know, one of the things that we try to deter the community from thinking is that the only time you use the contact center or 988 is if that you're suicidal. No, because mental health is such a huge umbrella. Maybe you're feeling overwhelmed. Maybe you're feeling depressed. Maybe you need linkages to community resources because some people get so frustrated trying to call and then they get referred to another number and then another number or another number. By that time they're like, oh, screw it, I don't want to do this. So this is where the CMO, and this is where we encourage people out in the community, give us a call. Even for providers, it could be overwhelming for you folks trying to deal with a person in crisis. Allow us to assist you and help you and support you as well.
Thank you.
So here it's just showing the dispatch time of a CMO, and normally I had made mention 45 minutes to an hour, so this is just showing you the data. Sometimes for Big Island or Kauai, it could be longer because Big Island is so big, right? Big Island is so big. So yeah, this is just showing you the arrival time. This is for Maui. Normally they're within the range, so it just shows you. So also we track how long it takes for the CMO to get there. Because sometimes if a person is in crisis and they're taking longer, those information gets tracked. It gets reported to us. And that's how we hone in on how we can improve services. And this is CSM by county. So it's showing you Hawaii, Honolulu, Kauai, all the authorizations and how long that they get CSM. Even if CSM is authorized for 30 days, should the person need more, and it's based off of the person in crisis needs, it could be extended. But that's a case by case. But the average time is 30 days. So CPSS. Okay, so the Certified Peer Specialist. Right now we don't have for right now, but it's an additional service that we do have. If you will think of CPSS as a person who is in recovery, a sponsor, right? So CPS is a person who has gone through mental health and they're in recovery right now. So it's a service that is offered for them. It's a wraparound service to guide the person who is a person in crisis to recovery.
This next part is about the crisis stabilization beds. And there's two different levels of care. One is the community-based stabilization beds, and the other one is called the licensed crisis residential shelters. Okay. So the LCRS by county. So there was about 265 authorizations provided for the Big Island, and then for Oahu, 490, followed by Maui, 190 in 2024. So one of the highlights of the LCRS is that the LCRS actually has a full-time nurse 24 hours a day that dispenses the medication. So when you're thinking about which way you should refer somebody for stabilization or LCRS, if your client would need to be able to have more of the medication monitoring by an RN and having it dispensed, then the LCRS might be a more appropriate level of care because they can actually focus on the medication efficacy, because you're having them dispense the medication. The person in crisis can talk about how it's helping or not helping or some of the side effects, and they can collaboratively work with your treatment team to be able to work with your provider too to see if there's any med changes that are needed during the time in which you're there and monitored. Okay, next.
And this is the stabilization bed. So if you will, emergency room is the highest level of care. LCRS is the lower, and SICM is right here. So the SICM, we don't have an RN available. So when referring client to a stabilization bed, they should be able to administer their own medication. They should be ambulatory and also do their ADLs. But through the SICM, they do receive the highest level of case management, which is,
sorry. So with stabilization bed, this is where they receive the highest level of case management. A lot of linkages to maybe needing a psychiatrist, maybe getting their meds, maybe mental health, maybe housing, maybe substance abuse. This is where it all happens. So regardless of case management, the client does receive the highest level of care during SICM. An average stay is normally 3 to 10 days.
Fast kind, because we have so much acronyms, and you're probably like, what is SICM? SICM stands for Stabilization Intensive Case Management. So that is what SICM stands for. Thank you. One other acronym, BHCC. BHCC is one of the newest parts of the crisis continuum, right? So whenever we look at things for our Hawaii Cares, we work with the entire spectrum of the crisis continuum. And this one's actually a very unique type of service because it has the combination of accepting referrals, but also being a drop-in center where a person can go and walk over there and knock at the door and get into the services. So they focus on more of like a living room setting. So if you see the picture, small kind looks like that, but a little bit different chairs. So it's instead of downstairs having beds, it's actually recliner chairs in which they sit there and hang out and have their stabilization for the 23 hours and 59 minutes. At that time, they're provided with care coordination and looking at what are their mental health needs, what are their social needs, what are their linkage needs, and then if they didn't need to have any kind of services beyond the 23 hours and 59 minutes, then they would return back to the community with some resources. If they needed to have more of a stay, then they would actually go ahead and look at the resources that might be available to provide them with like longer term services. Okay.
So this is just showing you our 2024 screening admissions and non-admissions for 2024.
And that's just pictures because we like to do these community outreaches just like today. We're having all these pictures. And so basically, if you guys want any presentations, just go ahead and email me or Sasha, and we can do virtual. We can come and do presentations. So just let us know.
I'm Nalu. I'm the substance use disorder. I'm going to be a little bit quicker because my thing with care started in April. So basically, I'll get a phone call. I'll do me and my staff, and we'll get an intake going. We'll refer to a provider if needed, but in this process, a lot of times, it takes a long time to get to a provider. So it takes about maybe 7 days to a week for an assessment, and then waiting for a bed space at our treatment center, that's like a month. So when they call, we're actually able to give them support while they're waiting to go into a treatment bed, because a lot of times what they think is they're gonna call me up and they're gonna go right into a bed, and they don't, or they're going to a treatment center and they'll try to get an assessment done, and that's not done on the spot right now. So I'm able to advocate for them and put them where they belong. So we screen, we use a KJ, basic intake form. It's kind of like a biopsychosocial a little bit. We focus on people who inject drugs and pregnant women trying to get help because high risk, right? And we start their episode of care. I'm a care coordinator. We'll send them to treatment centers that are more targeted for what needs they have. Oh, that was quiet. What? I thought I had more slides than that. Wait a minute. So, oh, yes, Emma, you go for it. Oh. Oh. Yes. Oh. So we're going into overtime for some reason. Never mind. So you can call the crisis line. You can get me. If you're still in crisis, we'll send them back to crisis. They'll get a caseworker. We'll get them treatment. We'll get them the help they need. I deal with a lot of families. So if they have family members that don't know how to deal with a person with substance abuse disorder, then I get a lot of families. But have them call, because I offer support. A lot of times the family member don't want to get help. So they have to learn how to build boundaries on their own. So.
And just to piggyback off of that, one of the beautiful things with how the program is set up is our wraparound services. Like what Nalu had mentioned, maybe treatment is like a week or a month or whatever it may be. We do have our stabilization beds as wraparound services if the person does meet criteria. So we want to reduce recidivism, right? So these are the services that can be in place for the consumer if they do meet criteria.
So we pow. Thank you.
Thank you.
Click, click, click. Are we doing questions? Are we doing questions? Yeah, we're in trouble.
Thank you guys for joining us for this session. We hope that you will come back and join us for, I'm blanking on the names, prevention efforts across the state, and then also behavioral health across cultures, which are our 2 other presentations later today. Thank you.